I'm Wanpen Vongpatansin. We're at the Hypertension 2025 meetings in Baltimore. I'm the clinical chair of the hypertension program here. And with me, I have Dr. Dan Jones. Very exciting. He's the chair of the AHA-ACC 2025 High Blood Pressure Guidelines, as well as Dr. Sadiya Khan, who's a member of the writing committee. So we have many questions that we want to discuss about these updates. So the first question I have for you, Dan, so what's the target and threshold for treatment of hypertension? What's new in these guidelines?
We do have a new target in this guideline. 130 was the target in 2017. And this guideline, we are using the word encouragement to a systolic blood pressure of 120. So the evidence supports 120. And so we say at least to 130 for our clinicians, but to 120 is really the ideal goal.
Excellent, excellent. And do we treat to this target to everyone, or who should be to get to a low range?
Everybody needs to be treated to this target. You know, this is really an amazing time in hypertension management because our goal blood pressure and our threshold are the same numbers, and how we define high blood pressure is the same. So we define high blood pressure beginning at 120, and we start treatment at 130, but with a goal of at least 130 and 120 if we can.
So I imagine a lot of patients going to have to take a lot more medication. What is in it for the patient that they need to know to get to this target?
Yeah, so since the 2017 guidelines were written, the biggest piece of good news for patients with hypertension is that treating hypertension reduces the risk of dementia. So we're all aware that treating high blood pressure reduces the risk of heart attack, of stroke, of kidney disease, and now we know with certainty because of recent studies that reducing blood pressure also reduces the risk for dementia. Such good news.
Yes, that's very important because many older adults might not care how long or much longer they live, but I'm sure they will enjoy the benefit of maintaining cognitive functioning later on. And what else that it's new in this one?
So the way we make treatment decisions around stage 1 hypertension, those between 130 and 139 systolic blood pressure, is a little different. One really piece of good news there is that we're using the new prevent risk model. We were using in the 2017 model the pool cohort equation. Now, thanks to Dr. Khan, we have a good risk model predictor in prevent. And so she'll explain maybe how we make decisions around stage 1 hypertension using a risk.
All right, Dr. Khan, take it away.
Yeah, this is a really exciting opportunity to be able to use a more accurate and precise risk model in the blood pressure guidelines. We know that people who have high blood pressure have different levels of cardiovascular disease risk. So being able to better understand who's at the highest risk so that we can treat those who are most likely to get benefit is really the point of using the prevent risk threshold. So we define in the guideline that for individuals who have a prevent CVD 10-year risk score of 7.5% or higher, so that means over the next 10 years, their risk of developing a cardiovascular disease event, which includes atherosclerotic cardiovascular disease like MI or stroke, as well as heart failure, is 7.5%, that they're recommended to initiate antihypertensive therapy in stage 1 hypertension, so 130 to 139 or greater than 80.
I see. And how do we find this risk score? Where can people look at it?
Yeah, great question. So the Prevent Calculator is available online on the AHA website. And one of the really exciting things is we're working to integrate it into the electronic medical record. As I think the most important thing that all clinicians are going to ask is how do we automate this to make it easier to use?
I see. And also that some question that might have come up is beyond this tool, there's some other way to certify the risk in the prior pool cohort equation. There's also an optional testing integrating other information like coronary calcium. How do we do that in this modality?
Yeah, it's a great point. With the primary prevention guidelines in 2019, the CPR framework was outlined, so calculate, personalize, reclassify. The idea being risk models are a great first step. They kind of give you a starting point to have that initial discussion between clinicians and patients. But there are other risk factors that we know of. For example, in the hypertension guidelines, we talk about electrocardiograms and having LPH. And so that's a great example, right? Even if your predicted risk score may be lower than 7.5%, if you have evidence of LBH, then treatment is recommended. And so thinking about how we bring all of the other characteristics together to be able to understand treatment is really important too. So coronary artery calcium, similarly, if you already have subclinical atherosclerosis or you have heart failure or other cardiovascular conditions, then we're going to recommend treatment regardless of what your estimated risk is.
And that's a really great point, because it means that it's not just looking at blood pressure alone, looking total patient clinical presentation and do the diligence to assess the risk so that we can get the right treatment for the right patient. And also the question on 7.5 versus 10%, is that because the general population have lower risks or because of the previous tool overestimate the risk? Can you help me understand it?
Yeah, it's a great point. It's actually kind of both. So the previous tool does overestimate risk. And so I think one thing that we really want to make sure we emphasize is that the pooled cohort equation 10% is the same as the prevent 7.5%. Because the models are different, the numbers are different, but it's intended to get at the same patient population that's at increased risk. Part of the reason it overestimates is because the pooled cohort equations were developed from data from the 1970s when the risk was higher. So we have seen over several decades risk come down, but that's why the pooled cohort equations is not relevant anymore.
On the final thoughts, do you have any other thing to add for these guidelines?
So these are days that we're thinking a lot about risk for our patients. And one of the new laboratory test recommendations is the urine albumin creatinine ratio, because of our increasing recognition of the relationship between metabolic disease, diabetes, obesity, and chronic kidney disease with cardiovascular disease, including stroke and dementia. And so clinicians in the past have used this as a test that was done sometimes and not done sometimes, but we think it should be done on every new patient with high blood pressure.
That's a very important message too. I think that a lot of these UACRs is not really done at all.
Right.
So we should doing it more. I would like to thank Dr. Jones and Dr. Khan for enlightening us about this new risk assessment and new 2025 high blood pressure guidelines. Very exciting time, lots to do. And we need to go back and see how we can implement this effectively in our clinical setting.